Welcome to this week's episode of the Caregivers Podcast. I'm your host, Dr. Mark Ropeleski, and you can call me Dr. Mark. My guest today is Dr. Jamaica Cass, the first Indigenous woman in Canada to earn both an MD and a PhD. She's a family physician helping reshape how future doctors are trained. Dr. Jamaica Cass, welcome to the Caregivers Podcast. We're so happy you're here with us today.
Thanks so much for the invitation to chat.
So tell me, why don't Indigenous communities trust the healthcare system anymore?
That is a big question with a lot of nuance. And it actually goes back much farther than you and I have been practicing. And so if we think back to the systems and structures that Indigenous peoples have been placed in since first contact. So we have the Royal Proclamation, which of course then turned into the Indian Act. We have things like the reserve system and the residential school system, forced and coerced sterilization, Indian TB hospitals where folks were cohorted with tuberculosis and had vaccinations tested on them without their knowledge. These are still very much in the recent memory of Indigenous peoples in Canada. And so this is a population of people who every time they have encountered these colonial institutions, that is the healthcare system, they have been harmed. They have been harmed and they still live in a system that often doesn't acknowledge that these things have happened. And so when that is your entire lived experience, I'm sure you can imagine how much terror and distrust there might be in the healthcare system in general. And then on the news and in the media, you're seeing stories about Indigenous peoples being left to die in emergency department waiting rooms or not taken seriously once they're admitted to hospital and then die because of that. And so I think it's really accurate to say that anti-Indigenous racism kills people in Canada still. And so with that context, of course, people are distrustful of the healthcare system.
When you describe healthcare as colonized, what does that actually look like in a hospital or a clinic setting in everyday life?
So Western healthcare, as those of us with MDs typically practice it, is very much set up in a way that models the systems and structures of European colonization as they're present in Canada today. And so we don't actually practice healthcare, we actually practice sick care, right?
Illness care,
and
right.
And so we don't actually consider health, wellness, and well-being. When we treat patients, we look for a problem and then we try to fix it or we try to manage it, right? And so you're automatically tackling the patient with a deficit-based lens. And so all of these concepts are very colonial. However, and there's significant diversity amongst the Indigenous cultures of Turtle Island, but I'm generalizing a little bit when I say that health and wellness is broad, right? There are different elements to health and wellness, and there are different elements to healing that might look like a traditional medicine, but that also might look like a ceremony or being on the land and connecting with the spirit. That might be, time with community, that might be healing through food. Like food is very much medicine, and culture is medicine, and that means different things for different Indigenous communities. That might be art, that might be dance. For me, it's beadwork, and these are really challenging concepts for Western healthcare providers to understand and process, and I think that's can be really, really challenging when you are trying to work with healthcare providers who maybe want to integrate some of these concepts into working respectfully in a care plan, but aren't really sure how.
I mean, many Canadians don't trust healthcare right now for many reasons also. Where is Indigenous mistrust similar, but where is it clearly different?
That's a great question. I think we all Indigenous people and non-Indigenous people alike see this strain on the healthcare system. So we see, rural emergency departments closing. We see surgeries being canceled. We see people, the people that are the foundation of the healthcare system. And I don't mean the doctors and nurses. I mean the people that keep the hospitals open, leaving healthcare. And that's pretty scary when you are the patient waiting for care or trying to access care and you can't, or you're on the gurney in the hallway, right? And that doesn't necessarily have to do with whether or not you're Indigenous. So I think there is alignment there, absolutely, in that worry and that concern about what kind of care you'll get. Where I think it's different is I think people that aren't Indigenous or don't identify with a racialized minority community aren't afraid to walk into the emergency department and have somebody accuse them of stealing or being drunk instead of being sick. And that's where I think kind of the difference starts.
Some patients sort of experience physicians and doctors in training as agents of the colonial system we've talked about, but that can occur even when a doctor is trying their best and meaning well. How does that gap between intent and impact show up in care and in the patient experience?
Yeah, that's a challenging one. So I think we all come into healthcare wanting to help people, right? Like that's inherently, I think, the folks that sign up to be frontline healthcare workers really do start out at least with the best of intentions. And I really, really try so hard in all of the different kind of hats that I wear to give people that benefit of the doubt there. But I think there's a big difference between kind of wanting to do your best and then doing the work to engage in the critical allyship required to really walk a path equally with an Indigenous person. And so you can say, I'm not a racist, or you can be anti-racist, right? And the difference between those two things is action. People that are anti-racist, when they see racism, they stand up to it, they use strong language, and they disrupt it when they see it. And that's a kind of the first example I can think of where there's kind of that difference between intent and action.
So breaking up the process and letting the dust settle and then actually listening to the patient in front of you. And I mean, when I think about it, sometimes it's actually there's a much bigger system issue too, because it's not just the physician who's the first to greet or meet the patient as they engage with the system, and there are numerous potential layers where things can be challenged. And what I love about some of the work you're doing is that it will incorporate new learning and new curricula, not only for physicians, but for nurses and for occupational therapists and physiotherapists as we build out the project up north, the Weeneebayko Queens Allyship, to build a new healthcare center, but also a healthcare curriculum, which we'll get into a little bit later. Can you tell me or take me to a moment where, in your experience, where Indigenous mistrust actually changed a patient's decision about the course of their care? What does that look like for our listeners?
Certainly, I have had patients have experiences where they delayed like attending emergency departments for fear and distrust and for fear that they'll be treated how, a family member or how they have been treated in the past. I have had patients share with me stories of, well, I went to this emergency department and they sent me away. They said it was a stomach ache. They said I had a stomach bug. And then they've gone to a different emergency department and they've had some testing done or imaging and an acute problem was found. And I think the two cases that I'm immediately thinking of, I think both ended up with like emergent surgery. And initially they were kind of told, they were essentially told they were fine and turned away. And I ask myself when I hear stories like that, because they're common, did that happen because of staffing shortages and physician burnout and all of these things, or was that racism?
It's very difficult to tease out at times, isn't it?
It is, yeah. And I'm mindful of the lens with which I hear these things, because it's certainly I'm getting it third hand.
Mm-hmm.
But I wonder, and I worry. I worry for my patients.
I mean, there's no doubt that modern medicine does save lives, but why should anyone believe that decolonizing medicine won't just slow down care and actually compromise results?
I think that's a really important question, and I guess maybe what I would share is just a little bit of information. And so Indigenous folks are about 5% of the population in Canada, but we are overusers of the healthcare system because the social determinants of health and the inequities that exist for Indigenous populations, again, as a result of colonization, are so significant that life expectancies are less and there's significantly higher rates of chronic disease in Indigenous populations. And so a significant, disproportion of healthcare dollars is spent on Indigenous peoples, not just in Ontario, but nationally. And so think about, imagine what would happen if all of a sudden our frontline healthcare workers could practice anti-racist, culturally safe care initially. All of those patients that are presenting late with these expensive chronic diseases would present earlier. And if you took the extra time up front to offer that culturally safe care, think of the time and money that would be saved. Nationally, it's surely in the hundreds of millions to billions.
I mean, there was a time when I think the Indigenous culture had built into itself those preventive elements of healthcare. I mean, some of those chronic diseases have evolved in rather recent generations, but there was a time where they didn't exist.
Absolutely.
And it does give hope for a return to greater awareness that maybe we can reverse that process and start changing that. I'd like to get into that a little bit later when we hear about some of your initiatives, but and that's not uncommon. I mean, we read a lot about not just lifespan, but health span. It's a very big buzzword these days, but it's highly relevant. And I've certainly, from my experiences, there's a lot of opportunity to build health span out, and I think we're hopefully seeing it in some of the younger generations of Indigenous peoples. That I've had some encounters where it has been more engaging, and there's an element of hope, and certainly reinforced in those contexts that I recall by my helping make my patient actually feel that I was invested in their care and their future and in the moment. And we all know how to do that. And adding a little bit more love and kindness to the equation, and everything that we do can just translate into so much momentum forward. And I think that should probably have to transcend this whole process. Shouldn't medicine just sort of focus on competence? I mean, think about it. Why do we bring history into it? If medicine can just focus on high quality competence, if we kept history aside and focused on the competence, wouldn't we be able to deliver uniform care across the board?
I guess it depends what your definition of competence is. That's a broad term. Competent in what?
Right.
Are we just talking about that biomedical model?
Mm-hmm.
Can you name all of the bones?
Right.
Tell me about the Krebs cycle.
Mm-hmm.
Or are we talking about maybe some of the softer skills? Like I'm competent with shared decision making and agenda setting and understanding the patient's social context so that I can offer a plan that not only moves us both toward a shared goal of wellness, but is patient's able to follow.
We're trained in the biopsychosocial model, but what I'm hearing from you is that what we really need to engage is in the adaptive biopsychosocial model, and informed by history and unique elements that are pertain to one culture and one community versus others. And it takes effort, and it takes that kind of knowledge, which hopefully the next generation of trainees here locally, and then when your successes spread globally, among other efforts to sort of shine light on how the right way of doing things is, that'll all change. Again, we often hear we want the best and the brightest in medicine, but that doesn't sound like it's enough, is it?
For a very long time, that's how merit was measured, right? The highest test scores and the best grades. And I don't know how much that serves us as a society, and I think of myself as a patient, how much that serves us, because I've now been teaching for some time clinically at the undergraduate, MD, and postgraduate family medicine residency level, and I can tell you that I have seen learners who had phenomenal grades and amazing test scores, and because they came through life with the power and privilege that I did not, they never had to struggle. And when they kind of come out into medicine and are now having to balance studying, taking care of themselves, doing all of the kind of daily things that as adults we take for granted, but they've maybe never had to do all of those things themselves before. And they get to that part of their lives where they're needing to balance all of these things and then deal with the rigors of postgraduate medical training. They really struggle. They struggle. And that makes me think about how important grit and resilience are in medicine, particularly in the current climate of medicine, and how hard it is to practice medicine with an aging population. People are getting sicker. There's less funding and money for things, and so we really all need that ability to be resilient. And I think when our up and coming folks in medicine lack that, I worry about their longevity.
It's interesting because we touched on this with Dr. Sanfilippo, who was on the podcast several episodes back, but there's also the resilience that comes in the face of clinical ambiguity, but perhaps even cultural ambiguity, where it's not just a melting pot of, fixed cultures. And even you say yourself within the Indigenous population, there's so much variation and fine-tuning of our approach. Just like dialects vary, cultures and traditions within the Indigenous population may vary so much as well. And it takes a certain skill set and, black and white thinking in terms of it's either this way or that way and no subtleties in between really doesn't get you far when you're trying to not only deal with clinical ambiguity, but the ambiguity that comes and how we have to modify our approach to be culturally sensitive and culturally safe. What do you think about that?
And I also think there's a humongous amount of humility and understanding that we don't know everything. And I think fundamentally, when we agree to be physicians, we have committed to a life of learning. And again, humility, have to have humility with that. And they say it's very dangerous to be the person who doesn't know what they don't know, right?
Oh, absolutely.
And so I think that's really important. There are some I think fundamental structural shifts that are coming because there has never been a provincial or national quality standard for cultural safety or Indigenous health in this country, despite the significant disparities in outcomes between Indigenous patients and non-Indigenous patients. And both of those are being created right now. And so really, for the first time, Indigenous patients in Canada, but also in Ontario, will have something they can hold in their hand to say, this is the quality of care I can expect and I deserve. And to be really honest, there actually is a legal obligation, right? Canada enacted the United Nations Declaration on the Rights of Indigenous Peoples Act in 2021. So it's actually now legislated that Indigenous peoples have the right to the highest attainable level of health. And we're starting to see that trickle down a little bit. And so when these quality standards are launched, institutions, providers, and patients and families will have a clear-cut understanding of the expectation that they treat patients with dignity, respect, and provide culturally safe care.
It's a lot more forward than just, a series of apologies I look forward to seeing that bear success. Tell me what you've championed in recent years through your involvement at Toronto Metropolitan University, but also more recently at Queen's, to forward this agenda so we have the right people in the right places to be able to honor these expectations of safe cultural care for our Indigenous peoples.
Yeah, absolutely. So I spent 2 years as the Indigenous Health Lead at Toronto Metropolitan University's new School of Medicine, which opened this past September in Brampton, Ontario. And that was a really unique opportunity. I worked on the senior leadership team for 2 years to help them embed reconciliation and decolonization into all aspects of the medical school. And so I got to work with the local Indigenous community to build culturally safe and barrier-free admissions processes. And they had a very high number of applications. I think they actually have the 2 years of admissions processes that they've run. We had a phenomenal amount of community engagement, like Indigenous community engagement, that went into curriculum building. I developed a 4-year mandatory Indigenous communities and health course so that every year TMU will graduate 94 physicians who have taken 4 years of courses to learn about the context of colonization and its impacts on health of Indigenous peoples and how to provide culturally safe care. If they don't pass it, they don't graduate. It is mandatory. We worked really hard to make sure that when we were going through all of the HR processes to bring on leaders as the school grew, that we were making sure we were asking hard questions about people's understanding and their actions around incorporating principles around decolonization and reconciliation and what their relationship was and where they were in their journey of reconciliation. And I think that I don't think those are things that have kind of ever been done before, kind of from the start. And I've now had an opportunity to go back and guest lecture a few times there, both at the postgrad level and at the undergrad level. And what a phenomenal group of learners they have there. And they're just just hearing the optimism and the vision they have for how they want to practice medicine it's really inspiring. And it was a great opportunity.
When medical schools start changing how doctors are trained in order to relate better to Indigenous patients, where do you sense or where do you see the pushback that people may have, and why does that still, or why could it occur?
So it's a little bit different depending on the context. And so I'll say I was very fortunate at TMU because we had a blank slate. And so we were building new curriculum. And prior to my coming on board, and actually the reason why I agreed to come on board is because the university had committed to it already. However, when we look at institutions who are updating and modifying curriculum, they sort of have something set already. And so there's always the question of where will it fit? Where will we put it? And I think there are lots of different areas and specialties that are kind of, I don't want to use the word fighting, but that are interested in kind of adding more content. And so I think that's a big challenge is just time. Where does it go? I think cost, right? It's not cheap. I think it's particularly important. We discussed the nuances of the diversity of Indigenous populations. I think when you're developing Indigenous curricula within a medical school, the geography is essential, right? Whose territory are you on? Whose land is this? And what do those relationships look like? If you want to have culturally safe curricula, you need to build relationships with the local Indigenous community, which takes time, which takes money, and then developing that curricula takes money. So of course it's expensive, and all universities are under financial pressures and strain right now. So that's challenging. I know that we've all heard the sort of anti-DEI rhetoric that is starting to shift north from the U.S. And when I kind of hear about that, I will remind people that Indigenous peoples have inherent treaty, constitutional, and legal rights that are different from other groups. And so you can't really lump in reconciliation work with DEI. And in fact, when you do, it's another form of erasure. And so I think it's really important that the Indigenous context be considered separately from other groups you might consider marginalized or equity deserving.
You said a couple of minutes ago, like, where will we put this effort? Where will we put this project? Where will it land? But right now, through your work at Queen's University and the Weeneebayko area Health Authority, we are actually building a landing pad, not just for physicians, but for allied healthcare providers as well. So tell me about that and the journey, where that's heading. I mean, I think it's so exciting, and I'm always glad to go up to Moose Factory to see patients and engage with some of my patients who I've traditionally seen here. But it's been a wonderful opportunity going up there and also feeling the pulse of excitement of what's to come and actually getting a tour of the new area that's being built. And so this is right off the press. You're right involved there. Tell me about where we're headed and the progress that's being made.
Yeah, absolutely. I think a common theme in rural and remote Indigenous communities is the challenge that comes with delivering care so far from urban centers. And there's a lot of challenges. There is finding providers, period. So getting all of the staff there and maintaining a staffing complement. There's staff that know and understand the nuance of the region and the unique challenges that come with living in those regions. And especially in rural and remote Indigenous communities, being able to provide culturally safe care and continuity of care, which is so crucial. And so there was a lot of groundwork that I cannot take credit for because I was not involved. But the MasterCard Foundation worked with our former dean, Jane Philpott, who's now working with the Ministry of Health in Ontario, of course, and then Lynn Innes as the CEO of the Health Authority, to really imagine what could be possible with, instead of pulling learners out of the region to learn health professions in these kind of bigger urban programs, what might it look like to deliver education differently, grounded in Indigenous ways of being, knowing, and doing, and delivered in community. And so what folks who don't live in those communities or have a good understanding might not realize is one of the many reasons why there are not more Indigenous healthcare providers, for example, is there is even a huge barrier with attending post-secondary education in rural and remote communities because high school teachers that can teach high school prerequisite courses to get into universities just aren't there. And so if teenagers want to go to university, they actually have to leave community to go south to a town or city with a high school to do high school. And so they have to leave their families, leave their communities, at least for high school, and then, of course, to attend education. And then when they get there, often they're not successful. And they don't fail due to academic reasons. Typically, it's sort of all of the other things. It's the culture shock. It's the lack of support, the lack of connection to community and culture and family, and then, also dealing with the, financial pressures and all of these things that other folks maybe just might not think about. And so with all of those things in mind, I am now the director of the Queen's Weeneebayko Health Education Program and have the distinct honor and privilege to work with the communities on the western coast of James and Hudson Bay to support bringing post-secondary education to the region. And so we are working to do that so that we can recruit, train, and then retain Indigenous peoples from the community to care for the community.
And that'll have so many forward positive impacts. And then imagine yet the next generation after that and so forth. That the power of that, I don't know if I'll still be around to see the final fruit born of that seed, but it's wonderful to hear. We have a tradition, Jamaica, of having the production team get a couple questions in too, just to add a different spin on the podcast. Are you cool with that?
Yeah, sure.
Did you guys have any questions today?
I'm just trying to think of some pushback that you might get in the TikTok comment section. There's people love to be keyboard warriors. Um, I get one of the main ones that sort of pops into the top of my head is there's the healthcare system is under so much strain right now, and there's like 6 million people without primary care doctors. And is I guess, is this the time to focus down on one particular group of people, when the entire system feels like it's ready to implode? And so I guess, one of the criticisms or pushback might be we need to get overall Canadian healthcare in a better place before we can, start to sort of focus down on one group or another. What would you sort of say to that sort of pushback?
That's a common one, and I hear it too. And that's kind of one of those times where I would, again, like, just purely, like, outside of my bias as an Indigenous person and a primary care provider, just go to the data, right? Like, I'm a researcher. And so if I tell you that, for example, in one community, the government is spending $10 million a year just to shuttle people back and forth because the care can't be provided in the region. That doesn't count housing them and the actual care provision, et cetera. That's just one part of their transportation. Then I'm sure you can quickly appreciate how those hundreds of millions of dollars in resources build up because of the inequity in being able to provide and receive care. And so again, the commitment to doing this, yes, I could tell you that it's a legal obligation, it's a treaty obligation, et cetera. That's one piece, and certainly it is. But it also is just good business. It just makes good economic sense to put the money in on the front end to develop healthcare workers who can deliver care in region, to bring, like, really truly to improve those health disparities and bring the health of the population, the quality of life up, so that we're not spending all of this money later with these late presentations and these expensive illnesses, dialysis, et cetera, right?
Makes sense. Maybe one last question. Do you find the support for these initiatives divided along any particular political lines, or is it more complex than that?
I haven't yet, which I actually think is really interesting and kind of speaks to Canada's ability to stand on its own according to its values and morals. Because, like, an example of the initiative that I'm working on, this education campus as a tri-partner initiative, I have institutional alignment up to the head of the university being so supportive. I have met with representatives in MCURES, which is the Ministry of Colleges, Universities, Research, Excellence and Security. I have met with folks at the Ministry of Health provincially, and the community is so supportive. So never have I actually seen so much, like, cross-sector alignment for one, like, initiative. And it actually, I was expecting that. I truly was, and I just haven't seen it. And I think everyone just understands how much benefit to the community there is just on all levels. Like, again, like, from a reconciliation standpoint, from an economic standpoint, from a health of the community standpoint, like, culturally, like, all of that. Like, it's hard to find a negative. And I think that the folks that I've seen, like, are understanding of that, and I think it's so great.
Well, we've enjoyed this tradition of having our production team participate in thought-provoking questions. We're back from the break and onwards with our guest, Dr. Jamaica Cass. Jamaica, when we say decolonize medicine, are we changing the science, or are we changing the system around it?
I certainly see that more as changing the systems and structures. And so I think part of decolonizing is inherent in that team-based approach. I know that, I'm a primary care provider, and that is sort of the way things are shifting, but I myself work for an interprofessional primary care team, and the ability to work with, like, an interprofessional team collegially and on the same level is absolutely a decolonized approach. I am not the most important person in the room because I'm a physician. Absolutely not. And again, like, that grounding in humility, like, I know when I need support from my allied health colleagues, et cetera. I think that's so crucial. That doesn't change the science. That doesn't change the medicine and that sort of Western MD lens that I see through. Although I do that with a culturally safe lens, But certainly I see us doing our best to change that system and that structure so that we can do the best for the patient with the resources that we have.
So when it's just you and the patient alone in the room and you're delivering a life-changing diagnosis, how does heritage and cultural identity matter in that moment?
It starts so much earlier than that moment is the first thing I will say. I'm really fortunate in that the clinic that I work for is an alternately funded model, and I have time with my patients. And so I've spent years establishing rapport with my patients and building that relationship. Like when you talk to Indigenous peoples and you talk about how to respectfully engage with Indigenous peoples, you're constantly going to hear how important relationships are. And that is just all the more crucial in medicine when people are coming in against this system and structure that they distrust and they need your advice, right? And they need support. And so I have spent years establishing like trusting relationships with my patients, like to the best of my ability. And I don't always get it right, of course, but it's something that I really work on and I really pay attention to. And it's really important to me in my practice as a physician, in modeling for my learners and in teaching to my learners. I really support them in that so that when there comes a time when there is delivering a life-changing diagnosis, they know that I'm there for them. And of course, frequently when things like this come about, I'm not necessarily going to be the provider that's providing the primary service for whatever it is, but they know that I'm always there. They know that I'm getting the results. They know that I'll support them through the side effects and that I'm reachable and that I'm there for them to connect them to other services they might need and the community is there for them. And I think kind of that's where the cultural grounding comes in.
A lot of that sounds holistically like just good medicine. But I heard you mention that sometimes you don't get it right. And maybe that might be more reflective of a deeper layer of distrust that even, for example, an Indigenous physician like yourself may not be able to establish. So are there different layers of mistrust? Are there, despite your qualifications at numerous levels, that trust is still very difficult to reestablish among very traumatized Indigenous people?
Absolutely. Like there's a spectrum and there's variance, right? Like no, just like any other population of people, there's not going to be everybody acting or doing the same thing. And I would say, sure, yeah, absolutely. I have patients that'll kind of come in and say, yep, okay, doc, sure. And then they walk out of my office and don't fill the prescription and don't go and see the specialist and don't go to the test and all of those things. And for a lot of reasons, distrust may be one of those reasons. So yeah, certainly.
You alluded to before and that you were trained in research and you go to the data. But to understand mistrust more and elements of how culture affects health outcomes, as part of decolonizing medicine, opening up new avenues to scientific data gathering and scientific interpreting, and do we need to turn to other scientific methods in a more decolonized healthcare system to really get the data that reflects what's going on in community?
I think more and more we are moving towards like Indigenous assessment methods and data collection methods to understand that the nuances of Indigenous communities, certainly. And so you might be looking at, whereas as opposed to looking at data and numbers, lab values, blood pressures, et cetera, you might be going into community and doing some community-based participatory research where the community actually drives the questions and tells you what is important. And then you take that and you work with them to establish evaluation methods that make sense for that community. And it might be different for every single one. I think another essential feature of understanding and working with an Indigenous community and the research in research anywhere is is making sure that you have, again, establishing those trusting relationships and understanding what data you're collecting, why you're collecting it, make sure the community understands how you're using it, where it's being stored, who has access to it, right? We call those with First Nations OCAP principles. But then, of course, when you're dealing with Métis and Inuit communities, they have their own like research ethics that you need to kind of be, that are nuanced and you need to be aware of. And I think that is where you're going to get really rich pieces of information that can inform not only care, but maybe what services or what gaps, what services, et cetera, are missing and needed. And I think more and more we are seeing that being accepted. That is, considered like still like now considered kind of more rigorous scientific research, as opposed to maybe it used to be less accepted and, for example, harder to get funded. But again, as we start to understand Indigenous populations as costing a lot of healthcare dollars, okay, what does it look like to work with communities to support them in understanding needs so that these gaps can be closed?
I imagine so much understanding of Indigenous culture comes from storytelling and narratives, that qualitative research will be an important factor in gathering a really good snapshot of when doing needs assessments of a community.
Yeah, absolutely. So storytelling is important culturally for a lot of reasons for Indigenous folks. So that was, how oral histories were traditionally passed down, right? So the learning and education was kind of done through storytelling. And a lot of the teachings I received, of course, have been through storytelling. And so that is just such an essential and a deeply rooted method of communication that, of course, it extends to research, right? And so what, in a colonial sense, you might call a semi-structured interview, when it comes to an Indigenous population, they might see it or receive it as like that exchange of information as being sort of a storytelling methodology. Yeah, absolutely.
So let's recap for our listeners now. If the science stays the same, what actually has to change to deliver modern medicine well in Indigenous communities?
Great question. So I want to come back to cultural safety for a second, because that term gets thrown around a lot. And I think a lot of people don't really understand what it means. And I want to just connect it with something you said earlier, which is like, that just sounds like good care. So cultural safety is an outcome. It's not something you do. It's a patient-defined outcome when you have a patient from a population, such as an Indigenous person, who feels that they've received care that is free of racism and discrimination, and that they were treated with dignity and respect as your equal. That's what cultural safety is. And so if you were to ask me, if the science stays the same, then what does it actually look like to have a positive clinical encounter with an Indigenous person? That's what I would say.
And delivering care to an Indigenous Canadian could be viewed as different from delivering care to someone from, let's say, Southeast Asia or another immigrant community. Are there spots where people get this confused?
I mean, I'm sure certainly there are, but I also think there's a lot of similarities. And so that comes to like taking your time, trying to understand the patient in front of you's like social and cultural context, asking questions with patience and humility and openness and honesty, and acknowledging your lack of understanding and your willingness to learn, doing things like coming down to the patient level and meeting them at eye level, and that establishment of rapport where you're speaking to them in plain language with an open and positive demeanor, and you allow enough time for the clinical encounter for this work to be done. And when it comes to the end of the encounter, you engage in that shared decision making so that you and your patient both understand what the plan is, and they have the capacity to engage with the plan, as opposed to the here's what you're going to do, and then the patient just nods and walks out, and you never see them again.
Absolutely. And that when things are aligned and you have that moment where a patient feels culturally safe, the way the room warms up is really quite an experience. And I've experienced it myself, and I'm sure you have many times, but it is a product of taking the time. And unfortunately, in much of the healthcare system these days, time is a dwindling currency, and we see it with our neighbors to the south and elsewhere where managed care allots only a certain amount of time for a patient encounter, and that certainly doesn't allow for the most culturally safe moments in care, or if anything, they had to be built up over several visits because it's not just a one-off link that forms.
You're absolutely right. And so one of the hats I wear outside of academia is co-chairing Ontario Health's first Quality Standards Advisory Council for Cultural Safety and Indigenous Health. And one of the things I've really advocated for in the quality standard at the provincial level is building in the expectation that providers, like institutions, give providers the capacity to have time to establish rapport to deliver culturally safe care, because I think it's missing. It's such a gap and it's so harmful.
But just, again, to the skeptics, given how strained the healthcare system really is, should medicine not aim to maybe just be culturally agnostic and just try and treat everyone the same, so at least a bare minimum standard is achieved? Or do you find that without cultural sensitivity, the bare minimum standard cannot be uniformly achieved?
I think the health disparities in Indigenous populations with the status quo speak for themselves.
Yeah, you're right.
And so I think if you put the time in on the front end, you'll reap the rewards on the back end.
So when Indigenous communities now who you're working with ask for trust, what do systems, what do hospitals, what do medical schools now struggle with the most to building that? And what parts of the past do they struggle with giving up?
I think societally, we all want a quick fix. And I think the biggest thing I can say, the sort of a feature that's probably present in all of those different areas is that, right? We need something quick, we need something cheap, we need something we can do now. And it will take time to rebuild that trust. Takes time. It starts with understanding the harms and the histories, right? That the first step in reconciliation is that truth telling. And so it starts with learning about the histories and the prior mistakes that have been made in the past, and the acknowledgement of those failures and those all of the harms that have been caused in the past, and then relationship building with the Indigenous peoples in the context of whichever institution you're talking about. And like all of these things, they take time, they take money, and I think, yeah, exactly. And you got to keep, and you have to keep showing up, right? Like you need to be in the room. Exactly. There need to be like indicators for success. There need to be accountability measures. Like if you don't do what you say you're going to do, what are the repercussions? Like all of those things need to be in place for this to work and be sustainable. And it's tough. And it's nuanced, and it's very like context and geography specific. And so it's also really challenging when there isn't a one size fits all fix for a problem. And so it's complex.
I mean, this is, as far as I'm concerned, under the umbrella caregiving for people now, caregiving for people of the future. But caregivers can burn out, can appreciate with these efforts and the obstacles and the challenges that burnout and trying to initiate change can be a reality for champions like yourself as well. How do teams of champions trying to change the landscape cope with the obstacles, and are people burning out trying to get there?
I have seen people certainly that have. I have seen, there are so many phenomenal Indigenous physicians who have come before me and done trailblazing work. And many of them have stepped back from that work because of the burnout and because of just constantly being asked to be the Indigenous person in a lot of places and spaces. But I find that when we as like advocates and leaders step up and drive change that aligns with our values, then we become supported by the systems that used to cause us harm. And then, like, for us, maybe the healing isn't stepping back, it's stepping upstream to drive that change, right? And knowing that we are making better places and spaces for the generations that come after us. And so I started out just being a primary care doctor in my home community. And all of the academic and clinical and research kind of work I do now in teaching kind of came out of the fact that I was constantly having patients come to me and describe these culturally unsafe and racist experiences within, the local healthcare system. And that just did not sit well with me as, to them, the face of the healthcare system. And so I started teaching cultural safety and anti-racist practices to, local family medicine residents and emergency medicine residents. I started building culturally safe admissions processes to remove barriers for Indigenous learners coming up, so there are more Indigenous doctors and Indigenous representation. I started doing some more kind of policy and clinic-based work, like things like cultural safety standards and looking at, at the College of Family Physicians level, like what does it look like to bring cultural safety and Indigenous health into residency training programs on kind of a more formal, uniform level across the country. Like, what might that do for care provided to Indigenous patients in future generations? And so that work gives me energy and optimism, and it allows me to then go back into community and have the energy and the drive to really provide culturally safe care to patients in my home community.
Your home community and your further away community up at Moosonee benefit from all of those efforts. Do you find that is taking community to the next level in terms of its ability to re-engage with trusting?
I hope that slowly over time it will. I am buoyed by, every time a patient tells me, I didn't tell the last doctor this, but ... and they've shared with me some problem or concern that they've had that they, at times in the past haven't felt safe, but with me they feel safe. And so I would say kind of slowly, there's certainly trust is coming back.
Considering those efforts that you just described and collective efforts, is there one thing that healthcare still does right now that just actively destroys Indigenous trust?
It's kind of a bucket or blanket term, but I still think there's just so much anti-Indigenous racism in the healthcare system. And that's, for me, that's probably the most important answer, I think.
How does improving Indigenous healthcare actually raise the standard of care for every Canadian?
Great question. I think that there are, as you've actually already pointed out, many transferable skills there. Wouldn't we all benefit from a healthcare provider who's just a little more empathetic, who is just a little more willing to hear our stories and hear what else might be going on in life besides your stomach ache or your sore toe, and take into context of their treatment plan some of that history. Like, these things, like, universally, I think will improve the patient experience and the care provided. It just is, a specific thing we identify as being crucial for Indigenous patients, but truly much of that would improve anybody's healthcare experience.
Any parting calls to action for our listeners? So thrilled to have shared today's episode with you and to hear from the front lines where positive change is being made. But a call to action to non-Indigenous caregivers, to up-and-coming and young Indigenous physicians and caregivers.
2, the first one maybe would be that educate yourselves. If anything I've said today resonates with you, do your homework. Read a little bit about, the Truth and Reconciliation Commission. Maybe read those calls to action. Read the In Plain Sight report from the BC First Nations Health Authority. Kind of get yourself an understanding of why this matters now, and it has to do with kind of the harms that have happened in the future, is the first one. And the second one, I would say, is don't commit to being not a racist, commit to being an anti-racist. When you see racism, disrupt it and make that your baseline moving forward. And if everybody did that, I think we'd have a much safer healthcare system.
Couldn't think of a better message to end today's episode with. Thanks for your time. Thanks for your story. And thanks for sharing.
My pleasure. Thanks so much for the invite.
We'll see you next time. I'm Dr. Mark, your host of the Caregivers Podcast. Thanks for joining us today. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.